I think it's about time. Good evening and good afternoon, wherever you are in the world. We are on to the last webinar of the seventh module, in which we have covered prostate cancer, locally advanced prostate cancer. And tonight we are going to discuss a few cases. I would like you to be involved in those cases, your comments, your suggestions, your opinion about management, and if you have questions. We are very fortunate to have Professor Athanasios Papasaurus, a very eminent academic urologist in the circles of both urolithiasis and also oncology. We had the good fortune of having to listen to his talk in the last webinar. So tonight we are going to discuss a few cases, and we will have the opinion from our learned professor. And also, if you have any questions, please feel free to ask. So without any further ado, I would just move on to the cases. So this is case number one, 68-year-old male who has a long history of low tract symptoms. And during the course of his management, he was found to have a PSA of 12.9. Again, a very significant PSA. His immediate response was to do an MRI pelvis. A multiparametric MRI was done, which shows a very enlarged prostate. He has been on alpha blocker and 5-alpha reductase inhibitor. The 5-alpha reductase was introduced rather recently, so in the last 3 months. This prostate was protruding into the base of the urinary bladder. There were multifocal, diffuse, hypointense areas in the transition zone. These are the so-called BPH nodules. There was no extracapsular extension, no pelvic lymphadenopathy. There was one hypointense T1 lesion in the L2 vertebral body, about which and one in the femoral head. But essentially, the radiologist was not very concerned about it being a metastatic deposit. His lesions in the prostate was rated as pyrate 5 because of the size. So based upon this, and these are the MRI scan, as you can see, it's a large prostate. This is a T2 weighted image. As you can see, the bladder is hyper intense. And this is a huge prostate, which is indenting into the bladder. And it was estimated to have a size of volume of about nearly 200 ml. This is T1 weighted scanning of the pelvis and abdomen. So no significant lymphadenopathy anywhere in the abdomen. Again, some of the T2 weighted image with diffusion restriction and DWI with ADC mapping. And you can see that the hyperintense lesion become hypointense in the DWI images, clearly indicating this is a malignant nodule. As you can also see in the picture on the above. So these are some of the more scans, and as you can see, a really huge prostate. Bone scan was performed before he underwent biopsy, and bone scan was unremarkable, particularly because of the presence of nodule, presence of lesion in T1 vertebral body and in the femoral head. A bone scan was performed before we did the biopsy. So, Thanos, question to you, would you consider any specific way of doing a biopsy in this case, considering the large, huge gland?
That's a very practical question, because actually it's good that you did an MRI prior to the biopsy, because in the past we were doing MRIs and we could not interpret the results. Now in the guidelines, the MRI is with a strong suggestion before the biopsy. And this is for 2 reasons. One reason is actually to give you the need to perform a biopsy, especially if you've got PIRATS 4 and 5. And if you have PIRATS 3 and the density is high, then again, you need to do a biopsy. So this is the one knowledge that we can have from the MRI. And secondly, we're going to perform MRI fusion biopsy. And the fusion biopsy, I believe, is better than cognitive biopsy. And now I believe that the trend worldwide is for the perineal MRI fusion biopsy. And in huge prostates like this, they are useful because you may lose actually the exact lesion. Here we have a big lesion, of course, but imagine if you have a small lesion in a huge prostate. In the past, we were doing saturation biopsies, meaning that we were taking many, many bites, and this increased, of course, the complications. So actually, what did you perform? MRI fusion, cognitive, and perineal, transrectal?
It was a transrectal ultrasound guided biopsy. The transperineal biopsy is still quite in the infancy at the moment. And the fusion biopsies are at the moment only cognitive because we do not have the transrectal probe for the MRI scan. So this was transrectal ultrasound guided 12-core biopsy. And particularly from the lesion, they have taken a few extra cores.
Yes.
So the pathology showed that it's a Gleason 3+3. 4 out of 12 cores were positive and prognostic group 1 with no perineural invasion. So this was the histopathology. And you can see that doesn't look a very nasty prostate on the biopsy itself. So what about 3+3 or prognostic group 1 cancers? What is your take on these histopathology?
So actually, it depends with the age of the patient. If the patient prefers to have active surveillance with 3 and 3, he can have active surveillance. And younger patients want to have active surveillance in order not to have the complications from intervention. But the problem is, what actually do we mean when we say active surveillance? Which is the protocol? There is no clear protocol all around the world. So personally, I advise regular measurements of PSA every 3 months to 6. Repeat the MRI every year and repeat the biopsy if needed. So if I have an increase of the PSA and also the MRI changes, then I may do a repeat biopsy to see if Gleason 3 is now 7. What we can do in addition to help our patients to be less anxious, because sometimes we say it's 3+3, but maybe we've missed another part of the lesion of the cancer because we know it's heterogeneous. It could be 7. So we have 10 to 20% where we have upgrade of the Gleason score. So in such cases, genetic tests are performed in the States and in some parts of Europe. And actually, for example, these are reimbursed. And the insurance companies reimburse genetic tests in order to actually subcategorize patients that are in low risk group to very low risk group. Because if you are very low risk group, then the chances of prognosis are less. For example, in Cyprus, where I also work, the state will reimburse the Polaris test for 3+3 in order to justify active surveillance. And sometimes they may reimburse 3+4 because also this is a better prognostic group, as you know. Sometimes young patients are anxious, so they say, "Oh, I want to minimize the prognosis, the progression of the cancer, and I want to have an operation, for example." I don't know if you have different protocols or in the NHS now they are using something different.
Yeah, so I think what Professor Thanos is pointing out is extremely important, that you need to individualize treatment. And this can be done at your level, but also more importantly, in a discussion with the multidisciplinary tumor boards or meetings. And you need to put this data into various algorithms
Algorithms.
that we
Yeah.
have. And one of the one that I have now been doing is the Cambridge Prognostic Group rating. So this calculator is available online. The Gleason group prognostic group is 1, is a T2 lesion, PSA of 12.6, his age is 68. And I mean, as far as the bone scan is concerned, there is no metastatic disease. And there is one question that is coming to on this issue, and I'll take it up. So based upon this, you put this data into the calculator, and it comes out to be CPG2. So CPG2, what it reads is that the prognosis for a CPG2 cancer is good, and the risk of dying of prostate cancer is low compared to the risk of dying of other causes. Now, another important thing that comes out from the Cambridge Prognostic Group calculator is the life expectancy of this patient. And again, this is something which is which varies in various racial groups and various countries. So this is European data, predominantly the UK data. And this person has an expectancy to live up to the age of 84 years. So it's a long period. And what discussion that we have earlier on from Professor Thanos was about the various modalities of treatment, and particularly patients who have a long life expectancy would like to have interventional treatment rather than active surveillance. As you know, that these are the various ways of assessing the prognosis. The EAU still uses the DMECO classification, which is based upon the tumor extent, PSA, and pathology from the systematic biopsies. The NCCN guidelines have introduced intermediate risk and subdivided it into two categories: the low risk and the unfavorable risk in the intermediate risk category. So if you have anything ISUP prognostic group 3, you have more than 50% of the biopsy scores positive. So if you have anything more than 2 of these intermediate risk factors, you become high risk in intermediate risk group category. The Cambridge Prognostic Group is a 5-tier model. And we have discussed this thing a couple of webinars back. I'm not going into the details of this. Again, intermediate risk is divided into CPG2 and 3. And you have, somebody has rightly pointed out, this is an intermediate risk cancer. Okay, so question about the 2 lesions that were seen. I'm sorry, I don't have the pictures of those lesions because the radiologist was quite sure that this is not metastatic. Would you consider doing a PSMA PAT here at this point, Thanos, before, if the patient, say, for example, decides for active surveillance rather than treatment?
Yes, absolutely. Actually, the PSMA PET now is very useful in cases before and after intervention. So in general, you're going to use a new diagnostic test if it may change your management plan. So it's very important to know if the disease is localized or if it's locally advanced. Sometimes it may be micrometastatic or oligometastatic. So the PSMA PET is better than the scan and the bone scan and the CT. And actually, there are some studies that compare doing the PSMA PET instead of doing the MRI, the CT scan, and the bone scan. So I would do the PSMA PET to be sure if these two lesions are metastasis or not. Thank you.
Thanks. Okay, so this patient decided for active surveillance, and we didn't do the PSMA PET, but I think that's an important point, and we may consider the reason why the board did not advise PSMA PET was because of his low Gleason grade. And PSA was considered as an indication of his huge gland. So we remember that PSA comes from the prostate, not from prostate cancer only. So a 300-gram or 200-gram prostate is going to produce a PSA which would be very close. If you determine the PSA density, it probably would not be very significant in this situation. So we move
Also,
on
if
to
I, sorry, if
yes,
I may
yes,
add,
yes.
also it's important to follow up your patients every year with a PSA. So if, for example, the case that we just discussed had a PSA of 9 a couple of years ago, 9 to go 12 is not a big deal from an aggressive cancer. But of course, if the PSA was 7 a year ago and now it's 12, then you will attribute this to the cancer. So always go back and check also the previous PSAs. It will be helpful. So thank you and sorry for interrupting.
Not at all. You're absolutely right. PSA velocity and also the PSA doubling time are two important ways of assessing and improving the quality of PSA in determining if you're dealing with a cancer or we're dealing with a BPH gland. Okay, so these are, I think, some important take-home messages from the last case. And I'm sure our delegates would benefit from this case. Now we move on to another case, and this patient was diagnosed with prostate cancer some time back. He had an open radical prostatectomy about 5 years back. He's a very active person. It was diagnosed at a rather young age. He does not have any significant family history, but it was in the early 50s that he was diagnosed with prostate cancer. His PSA at that time was 4.5. His 12 core biopsy indicated a very aggressive cancer with a single core of Gleason of 4 plus 5 is equal to 9 and two cores of 3 plus 4, 7. So he had an open radical prostatectomy, and his pathology indicated Gleason of 4 plus 5, no extracapsular extension, negative surgical margins, and negative lymph nodes, negative seminal vesicles. If we look at the DMECO classification and the EAU classification for development of biochemical recurrence, we see that he does fall into, because of the Gleason, falls into a really higher chances of developing biochemical recurrence. So this is his scores. His PSA, the first PSA after 2 months of radical prostatectomy was undetectable. He achieved trifecta for 5 years. His PSA, his potency, and his continence were all within acceptable ranges. And after 5 years, in the last 1 year, his PSA started to rise. And this is the PSA progression, as you can see, from 0.01 in 2023 to the current 0.2 nanograms per ml. So although the rise is gradual, and the PSA doubling time is also slow, because in June 24, he was 0.09, which is 0.01 actually. So from June 24 to June 25, his PSA has doubled. So the doubling time is about a year. So what would you do next, Thanos? You are muted.
Yes, yes. So this is a very interesting case because we need to know that biochemical recurrence is actually very usual in high-risk patients. Up to 30% of high-risk patients will have biochemical recurrence within 2 to 3 years. And that's why there are some proposals actually in patients that are diagnosed with high-risk prostate cancer. And here the Gleason score of 9 is actually a very, very important point to give even the new antiandrogens early enough so that they won't develop biochemical recurrence. Because as you know, once biochemical recurrence takes place, the next steps of progression may follow. So at this point, 0.2 is a point where we should do a PSMA PET. And actually in Greece, it's reimbursed, this imaging, if the PSA is above 0.2. So that's what I would do. I would do a PSMA PET scan.
Okay, good. So that's an important point. One of the lessons that is that PSMA PET cutoff used is 0.2. Anything less than that, the chances of PSMA PET being positive is low. So it is generally not indicated in that situation, as pointed out by Thanos. So the question that was about to ask was, which he already answered, about what next, either CT scan and a bone scan or PSMA PET. But clearly, that PSMA PET is a much more sensitive imaging modality compared to CT and bone scan, and very likely that it would pick up something if it is present, unless it's very micrometastatic. So PSMA PET be done? Yes, the answer is that it should be done. And very likely the recurrence is to be in the prostatic bed. And in that situation, if PSMA PET picks up something, local treatment could be advised, including radiotherapy. So the question about PSA and PSMA PET, we have already talked about. It's 0.2 is the cutoff. If there is a positive lymph node that we pick up on PSMA PET, again, our modality of management would change. If we have a negative PSMA PET, what would you do then? So PSMA PET was done, and it came out to be negative. There was no detectable lesion on the PSMA PET. So the question is, what next? And you have one of the 4 options here, but we can discuss if there is any other option that comes to your mind. So Thanos, what would you do next?
Yes, actually, we have biochemical recurrence, high risk patient. I would do hormone therapy and book him for radiation. And then I would continue the hormone therapy for 3 years. That would be my suggestion, but of course, this is discussed in the MDT setting.
So in the absence of detectable lesion on imaging, you would still consider irradiating the prostatic bed?
Yes, because he's high risk.
But there's a time period of about 5 years in between as well. And during that period, he stayed pretty stable.
Yes, you are right with current knowledge, but once you have the results of the new studies, you're going to see that for high risk patients, the license would be for apalutamide, enzalutamide, and darolutamide. Now they're going to give this medication. So either we wait, but this can happen later on. I'm very, very concerned with a Gleason score of 9. He's quite young, okay, and there is a case of the side effects of radiation. But if we want to guarantee that this case won't progress, that's the only way. But we can wait again and have follow-up of the PSA. So what did you actually do in this case?
Okay, so we put all these things on the table, and while we were discussing this, just for the sake of our delegates, that we need to remember that a PSMA PET is very sensitive, but PSMA PET is not 100% accurate. PSMA PET can miss tumors in about 10% of cases. So there are non-PSMA producing prostate cancer cells which can be missed on PSMA PET scan. And these 10% tumors which are not producing PSMA are actually much more aggressive cancers. And that's probably one of the reasons why Professor Papasaurus suggested active treatment in this situation. The question really is that are we dealing with only local recurrence, or we are dealing with systemic disease and there is micrometastatic cancer? So the rationale of using some form of a systemic therapy, which is in the form of androgen ablation, is a very sensible way if you want to supplement it with the local radiation therapy. So I agree with you, Papasaurus, about how this case be managed, which means that he should be treated aggressively, not only with local treatment, because this is probably where the disease is at the moment, and although we are not able to document that, and also giving something systemic for micrometastatic disease. So we did exactly that with local radiation and ADT.
And may I add the last comment for this very interesting case? There are studies now that actually for high-risk patients and very high-risk patients, because this is a very high-risk patient with a Gleason score of 9, they actually administer antiandrogens like apalutamide for 6 to 12 months after the operation, and they monitor the PSA for 2 years. In these cases, there was no biochemical recurrence, 2 to 3 years, and they compared with patients that took only LHRH agonists. And in there were cases that maybe they had biochemical recurrence when they stopped the LHRH. So what I'm saying is that always be cautious when you deal with a patient that has, in his age of 50 something, an aggressive prostate cancer. These are cases of hereditary prostate cancer. And if you go through the algorithms, like the CAPRA score, the California algorithm, the diagnosis of prostate cancer below the age of 55 gives you 1 point. So it makes the prognosis worse. So these are my comments, and congratulations for your presentation once again.
Thanks. Okay, so this is the last case for the evening. 61-year-old male. He loves to eat meat. And he has low urinary tract symptom with nocturia, is a former smoker, 15-pack year history. Nothing significant in his past medical history. His mother was treated with a breast cancer when she was about 50 years of age. During his management of low urinary tract symptoms, BPH, he got his PSA, which comes out to be 36. So further workup with imaging indicated a clinically T3 cancer. His biopsy indicated 4+4 ISUP grade group 4, and the bone scan also indicated 3 spots in the spine. The CT scan showed locally advanced prostate cancer, some lymph nodes, and a spot in the lung, which the radiologists think is his healed pneumonia from the past and not metastasis, but there was split of opinion. His ECOG performance status is 1. So a question to our delegate, and then we'll have comments from our expert tonight. Would you go for ADT monotherapy, ADT plus ARPI, ADT plus docetaxel, or ADT plus enzalutamide? So you can type your answer in the chat box. So we have 1B, 1C, 1D. So it's a bit of a split of opinion. So most of you are going for C and C and B. In fact, there are more Bs now than C. Okay, any comments, Thanos?
So this is a case of de novo metastatic prostate cancer patient, and we as urologists have such cases. As we all know now, ADT monotherapy is not enough. In the past, we were just giving ADT, but this is now wrong. So I'm happy that everyone missed option A. And regarding option C, in the past, we were actually referring such patients to oncologists, medical oncologists for chemo. But actually, not only because we are urologists and we should give whatever we can give and control, studies have shown that the combination of ADT with the new anti-androgens could be superior to the combination of ADT with chemo. And we need to take into account that it's de novo metastatic prostate cancer, low volume, because we have 3 spots on the spine. And as you know, charted study has discriminated low and high volume disease regarding the position and the number of the metastases. So I wouldn't go for C. I would consider B or D. And actually in Greece, D is the option because abiraterone is not reimbursed for low risk, for low burden. So I would go B or D. I believe most of you would go for B, or B was your option?
Yes. So majority voted for B, and because abiraterone is available and it is there is in majority of the centers, it is patient who himself or her pay for the, so insurance is not a big factor in Pakistan medical care system.
And if I may comment, now abiraterone the last 2 years is generic also.
Yes.
So it's cheaper all around the world, and that's very important also to know.
Yeah. Great. So if that lesion in the lung is suspicious to be malignant, which is very unlikely considering his overall, would you have considered a referral to medical oncologist for consideration of chemotherapy?
Yes, it could be an option actually.
Yeah. Okay, so this was an initial survey that was circulated, and again, ADT plus abiraterone is the most frequent answer. And I think most of these things have already been explained by Professor Papasaurus about the various evidence that is available now that the Latitude and the Stampede trial clearly indicated that addition of abiraterone early on in metastatic hormone-sensitive prostate cancer de novo, addition of abiraterone and actually makes a significant impact on the progression-free survival in these patients. Another factor about the cost of abiraterone or ARPIs versus use of docetaxel. One of the indication for use of docetaxel in this setting is that docetaxel is compared to abiraterone long-term is relatively cheaper. So that's one of the reasons why sometimes people go for So the conclusion from the tumor board was that it's a de novo metastatic prostate cancer with bone and lymph node metastases, a doubtful lung lesion, poor prognosis, high-risk disease, and he should have a PSMA PET before we start treatment. So PSMA PET was done, which basically indicated that the lung lesion have a very low SUV, and it was not considered as suspicious of malignancy. Rest of the lesion identified on the conventional imaging were confirmed to be with metastatic bone disease as well as the primary prostate. Okay, so there was a mention about, particularly on our second case, who was diagnosed at the age of 51, and he is now with a biochemical recurrence at 55 years of age. And we see that there is a very strong possibility of genetics involved in these patients rather than a de novo prostate cancers. So it's important that for certain indications, and one of the indication is young age at diagnosis or family history, or unusually aggressive cancers, the BRCA1, BRCA2 screening be done. In the third case, this patient had a history of breast cancer in his mother. So, Thanos, is in your country, is it one of the reimbursable reason for if your family member, like a mother, had a breast cancer for BRCA screening?
No, actually, still reimbursement for BRCA1 and 2 is a problem. We would suggest this in a very young age, and in cases of metastatic castration-resistant prostate cancer. Because hormone sensitive, even de novo disease is not always a problem regarding the need for the new PARP inhibitors, because as we all know, when we order a test is when this test will help us use a relevant treatment. So the reason for actually measuring the BRCA once you've diagnosed the disease is to see if they are BRCA2, because this is the most frequent mutation, BRCA2, and then BRCA1. If they are positive, these mutations, then these patients will benefit from the administration of PARP inhibitors like olaparib. And this is once the disease has progressed to metastatic castration status. So for this exact patient, I wouldn't, but of course, we always ask for both parents the history, not only for the father. Thank you.
Thanks. So as mentioned, BRCA1, BRCA2 mutations increases your risk of prostate cancer, but it is not invariable. So if you have a BRCA2 mutation, for example, or BRCA1 mutation, it is not invariable that you would develop a prostate cancer. It increases your risk compared to those who do not have BRCA mutation. BRCA2, as mentioned, is considered a strong negative prognostic factor as well. It is linked with more aggressive disease. And in fact, in the West, where this screening is more readily available, uh, patients who have rather unusually aggressive cancers are also screened for BRCA mutation. So in cases if you have a positive patient with BRCA mutation, early and more frequent cancer screening is recommended. Now, just a quick word about some of the new androgen receptor pathway inhibitors and some of the new drugs which are available now out of besides the ADT, because that's what the bread and butter of treatment is in most part of the world. However, there are a group of new agents which are available, and there is strong clinical evidence and research evidence for its utility. We know that the ARPIs include abiraterone, enzalutamide, and some of the newer agents, which is apalutamide and darolutamide. And if you look at the EAU guidelines about these five clinical situation, high risk localized and locally advanced disease, high risk biochemical recurrence, metastatic hormone sensitive prostate cancer, non-metastatic CRPC, and metastatic CRPC. So which agent is recommended in which situation? And we have discussed some of these things already in relation to our three cases. This is what the EAU guidelines recommend. Enzalutamide is the primary agent that you use for high-risk BCR, whereas abiraterone is really indicated in most situation of your metastatic CRPC, metastatic hormone-sensitive prostate cancer, and locally advanced disease, as we have seen in our patient. The newer agent, apalutamide, darolutamide, unfortunately, are not available in Pakistan, but there is very good evidence available now for its use, particularly in metastatic hormone-sensitive and non-metastatic CRPC. Then we need to know what is CRPC. For the diagnosis of CRPC, it's important that you have a castrate levels of testosterone, which is less than 50 nanograms per deciliter or less than 1.7 nanomoles. And in this situation, once you have diagnosed CRPC, if the levels are low, then the diagnosis is either based upon biochemical progression, radiological progression, or clinical progression. Biochemical progression is 3 consecutive rise in PSA. And I'm just recapping, most of these things have already been discussed just before you have your exit MCQ in about next few minutes. They should be done at least 1 week apart, and that results in a 50% increase over the nadir value that you have achieved after definitive treatment. The radiological progression, 2 or more new bone lesions on the bone scan, or if you apply for the soft tissue, the RECIST criteria for evaluation of solid tumors. There is symptomatic progression alone is question and require further investigation. There is no good quality evidence that just based upon symptoms, you would make a decision about biochemical. However, if there is unequivocal clinical progression of disease without any of the previously mentioned factors, the CRPC state is considered and treatment is started. Now, what do we have for metastatic CRPC at the moment? So we have 2 chemotherapeutic agents, which is docetaxel and cabazitaxel. We have 2 ARPIs, which is abiraterone with PRED and enzalutamide. And we have, as mentioned earlier, that if you have a BRCA mutation, then some of the PARP inhibitors, which include olaparib and some of the other newer ones, are there. For predominantly high volume bone disease, you have radium-223, and a newer agent called lutetium-171. And we'll have a little word from Thanos about are all these agents available in your country and do you use them?
Yes, actually, in whole Europe, all these agents are uh, um, approved for the uses in this disease phase, because this actually stage is the potentially lethal stage. So it's very important to actually give whatever you can in order to stop the progression. And it's very important not to have symptomatic disease at this stage, because then you don't have many things to apply. And actually, in Europe, the combination of olaparib with abiraterone, because olaparib is not given alone, it's given with abiraterone, uh, is approved for all comers, both BRCA mutated and non-BRCA mutated. EMA has approved this because the relevant studies have shown a benefit. But the biggest benefit is for BRCA mutated patients. And in the States, the FDA has approved olaparib with abiraterone only in BRCA mutated. So in different places, you have different policies, but the good thing is now that prostate cancer is like a chronic disease where all these stages may take months and years. And what you must do is actually be very cautious in order to delay the progression. And you can see that we have chemo, we have immunotherapy, we have new things that we can use, and also the new anti-androgens that we can use. So in the past, when we had metastatic castration-resistant disease, we referred these patients to the oncologist. But now we can also take care of these patients because these patients trust us. So that's my final comment for this.
Thank you. What the EAU recommends about non-metastatic CRPC is the use of the new ARPIs, which is darolutamide and apalutamide. What about sequencing? So, for example, if your patient has been on one ARPI, say it's abiraterone, do you move on to the next ARPI, which is, say, enzalutamide or darolutamide or apalutamide? Well, the evidence is that there is significant cross-resistance between ARPIs. On one ARPI, and there are high-risk features for rapid progression are present, it is not sensible to move from one ARPI to another one. What about sequencing one chemotherapeutic agent with another one? So from docetaxel to cabazitaxel, well, if it is applied early enough, the patient is still fit for chemotherapy. Sequencing is considered and it has advantage and it's supported by high level of evidence. Okay, PARP inhibitor, I think we have already talked about this thing. I don't think we have time to discuss. We all know that the HRR mutations, which is most commonly the BRCA1, BRCA2, and HOX3 mutations, they result in repair of the DNA damage. And PARP protein is basically involved in that process. And if you give PARP inhibitors, you block that DNA damage repair mechanism. And as a consequence, the cancer cells will die. And this is really recommended, particularly in BRCA mutated patients. Radium-223 is very much like strontium and calcium is preferentially taken up by the bones. So it is something which is extremely helpful if you have predominantly bone metastatic disease. These are some of the guidelines, and I think most of these points have already been talked about. And as you can see, for majority of these things, we have very high quality evidence available and strongly recommended by the EAU guidelines about management of these patients. And as mentioned by Thanos, it's a chronic disease and requires lifelong. And we are not only looking at the oncological outcome, we are looking at the management of bone disease, which is the major killer in these patients, because this is where the bulk of metastatic disease is, and bone is itself site for various medical complications, surgical complications like skeletal related events, and use of these hormonal agents have a significant psychological as well as medical impact and quality of life. That's also comes now under the domain of urologists to manage. So I'll stop here. Any final comments, Thanos?
No, you actually did a very nice summary of the most important issues, and this series is very helpful because actually we deal with patients that will suffer either from benign disease or from prostatic cancer. So prostate is an organ where urologists should be very, very knowledgeable regarding this. And my only comment is regarding non-metastatic disease. This is according to the standard staging imaging tests. If we perform PSMA PET in these patients, a big majority will actually turn to metastatic disease, oligometastatic, but also is something that we need to take into consideration. So you said everything that practically could be said within 1 hour. And thank you once again for the kind invitation, and have the need to congratulate you once again. Thank you.
Thank you very much, Professor Papasaurus. Very, very valuable comments, very practical tips to our delegates. And I'm sure they must have benefited from your vast experience in this regard. So thank you very much for being here tonight. Hope to see you soon in Taiwan.
All the best. Thanks a lot and take care. Thank you. Bye-bye.
Bye. So the MCQs on module 6 and 7 are shared in the chat box. You can just click the link, and if there is any issue, please do let us know. There are 19 MCQs. As always, you can mark your questions and it will come to us, and we'll hopefully share the result as soon as possible. So all of you are able to download the questionnaire.